So welcome and thank you all for taking the time. Sophie, you've come from Adelaide.
Mount Gambier, actually.
Not Adelaide, of course. Limestone Coast, 500 kilometres from Adelaide. So thank you for making that big trip. I might start with Emily. You're at the start of the conveyor belt. Kick us off. How bad is this vaping? Let's hear the kind of shocking stories, I guess.
Shockers.
Yeah, shockers.
Yeah, I guess when we think about ultimately what we're trying to do with this program is prevent the use of vapes, but why? You know, what is it about them that's so concerning to us? If we think about an old conventional cigarette, right? So it has a certain amount of nicotine in it, you burn it, it has a limited time that you're using it, and these days, because of the very comprehensive public health approach we've had in Australia, you can't smoke inside, you know, smoking is incredibly expensive through the tax excise. It's hard to do and it's expensive to do. Vaping gets around almost all of these things. It's easy to do. It's surreptitious, it tastes good, you don't get throat burn, it delivers nicotine much faster than a conventional cigarette, the doses are higher, the actual formulation of nicotine that's inside a vape has an acid added to it, so it smooths out the feeling when it goes into your lungs. So it's more palatable. What that means is you can get more of it. The batteries, some of these have 10, 15,000, Becky, you'll know more about this as well, puff capacity in them. So unlike a cigarette which ends when it goes out and you've got to go back inside and keep having dinner and pretend that you haven't smoked, they keep going. They keep going. So you can vape and vape and vape to the point, if you're a young person, you will vomit. You might have a seizure. The other thing we've got to think about why they're so scary is that they aren't, as Mark Butler and Mark Scott alluded to, these therapeutic devices that magically reduce smoking rates. They can be helpful for some. They were not designed to do that. They are incredibly tasty. We did some focus groups with young Aboriginal kids on the Central Coast as part of a related project, and they said, oh, you know, you're on the dance floor and you feel really bad, you might have just had dinner. If you just take a hit of a Kiwi Crush vape, and then you kiss someone, it's so much better. So the flavours are so appealing. But the adolescent brain, so we're talking about kids aged from 12 up to 26, really, your brain is still developing. And at that time, your brain is highly receptive to dopamine and to drugs. Your brain is neuroplastic. The influence you get on that brain can basically set how your brain works for the rest of your life. So if you're getting these massive doses of nicotine, and they are higher, some of them are up to 50 times the amount of a pack of cigarettes, paired with the flavour, paired with the social acceptability, paired with the ability to get them quite cheaply and surreptitiously, you're giving adolescent brains massive doses of nicotine that can change how they're wired. So this is what's so scary about it. So we're talking about long-term nicotine addiction, that once you're addicted to nicotine, it is the hardest drug to get off. But then it can lead into other things, like the biggest concern for us is the lead into smoking. And the lead into other substance use, because it's all that same reward pathway. So look, long story short, pretty scary.
Yeah. And if I can add, you know, some data to that. So in the Limestone Coast, we were part of the Planet Youth trial, which I'm not sure whether people have heard about, but the Alcohol and Drug Foundation funded the Planet Youth trial, which came from Iceland, which surveys kids in schools, 15-year-olds, so year 10s, around their drug and alcohol use and lifestyle factors. And what we saw, and I'll call it the COVID survey, was that up to 41% of year 10s had vaped in their lifetime, and 19% were vaping daily. And it was the kids who were playing sport who were really attracted to this behaviour. Which, you know, I mean, it frightened the hell out of us, or me. And yeah, so from there, that's why it's not why, but it added to the point for me as to why we need to do evidence-based drug and alcohol education in schools, which we push for all of our Limestone Coast secondary schools to do, of which there's 16.
Yeah, amazing. And you said to me, Sophie, that if they don't get the prevention education, they'll get it from somewhere else. They'll get it from the year 10 kid that's doing drugs or smoking or alcohol.
That's right.
That's where they'll find out all about
the myths.
But yeah, the myths, right? So
that's right. Yeah.
It's so important. Dr. Brian, you're at the other end of things where you're seeing acute trauma, right? You're seeing young people come in. When I chatted to you, I just had this sense of like whack-a-mole. Like you literally don't know what sort of chemicals are in these products and what's caused this, acute failure that young people have had.
Yeah.
What's it like at the front line?
Well, I think Emily's just described the recipe for disaster, which this scourge is. It is an epidemic among adolescents, and that's a problem. It's been a surreptitious one that's just come up very slowly. It arrived very quickly, and now it's coming right up. There's two main concerns that we have as acute care physicians with this. One is the nicotine dose is extremely high, and that can lead to seizures. It affects your cardiovascular system as well, so you can get very fast heart rate. Your heart can remodel, and that can become a problem. And the seizure is often seen as not a particularly big issue. It can be a major problem. If you have a seizure that goes unrecognized, or you block your airway, you die, or you have hypoxic brain injury, and you're in ICU for weeks, and potentially you could die. So that's a big concern. The other thing is not just the nicotine, is the actual substance that's in the vape itself that aerosolizes, and we don't know what's in that. So there is no knowledge that we have of what's in that. So when one of these kids comes into the emergency department, we do not know, besides nicotine, we don't know what else is in it, and we just have to treat accordingly. What we do know is that kids are particularly more prone, or adolescents are more prone to vape-associated lung injury, which basically just destroys the lung architecture. So those aerosols destroy the lung. Sometimes it can be irreversible. It can cause the lung to develop a hole in the lung called a pneumothorax. They sometimes need a drain put in their chest. Sometimes they need oxygen. Sometimes they need mechanical ventilation, so we have to anaesthetize them, put them on a ventilator. And sometimes that doesn't even work, and we have to put them on heart-lung bypass machines, which is a big cost. And the big, when I look at this research as a clinician, and also I do some clinical research, this is game-changing. This is how translational research should be done. And I think this is one of the most exciting things I've seen in years, because we've taken a problem, it's an emerging big problem, we've provided a solution that's scalable, and the scalability of this is something that resonates with me in particular, because it's doable, it's going to reach a lot of kids, and it'll decrease harm. And the cost of healthcare for these adolescents is extremely large. This will save billions, I imagine, in healthcare. So this is phenomenal. We don't know also, compared to smoking, we have a lot of long-term data in smoking. We know it causes cancer, X, Y, Z. We don't know with vaping what the long-term effects are on the lungs. And when you speak to respiratory physicians, they're not sure either. So we do not know what the permanent damage is to kids who do this.
It's, even last week we had vapes with nitazines in them, and all this really shocking stuff. Megan, I'm going to switch gears a bit. From a curriculum perspective and from the education side of things, like how do you design the curriculum in a way, like this is all fast, right? Like this vaping wasn't there 5 years ago, maybe a bit longer.
Absolutely.
And then we've got new things coming and new devices and new drugs. How do you kind of cope? How do you help teachers? Two things actually. How do you build the curriculum in a way that allows teachers to kind of incorporate that stuff? And then more importantly, how do you guide teachers in making the right decisions for the types of programs and education resources that they use?
So embedding this work into curriculum is really important, because that is the right for every student in our schools to access that content and that knowledge and those skills. So embedding it in our curriculum is really important. And then also the evidence base that it's built on that really shows to us what is going to be effective. So schools are incredibly busy places, and those scary stories that you just described are playing out in our schools. They're playing out in our classrooms. Our school leaders are trying to manage those things, and it's not just the health concerns, but it's the impact that has on learning. It's the disruption to learning. It's the lack of concentration, all of those things that have those impacts as well. So our teachers are dealing with many things, and I was reflecting with Brian before, whenever there's an issue in society, it comes into our schools. So whether it's vaping, whether it's respectful relationships, consent, anti-racism, it's all in our schools. So the more we can support our teachers with that strong evidence-based approach, with effective teaching and learning practice, where we give them the tools, we give them the quality assured, evidence-based materials, resources, lessons, whatever it might be, to do their job effectively, that's enormously supportive for our teachers. They are busy, we know that, and so if we can cut down on that workload and give them the stuff that we know works, that's gold. And in terms of how do we keep fresh, and how do we know, well, not fresh so much, but how do we create a curriculum, which is not my job, by the way. I don't create the curriculum. I support schools to implement the curriculum. It's about having a curriculum that is flexible enough to be able to work with whatever is emerging at the time. Right. And a lot of the skills that we teach students around that critical thinking and how to be problem solvers and to make those decisions about their own health and well-being, those things sit in that syllabus. And so whatever the next thing is that's coming our way, the curriculum is flexible enough to be able to manage that. So, yeah.
In South Australia, Megan, we have the South Australian education, not that I'm an expert because I don't work in schools, although I have, but not currently. They have the child protection curriculum where drugs and alcohol sits. What I have found is it's very difficult to change schools from using old hat stuff that isn't evidence-based into using state-of-the-art evidence-based drug and alcohol education which talks to kids' values, friendships, how to look after each other, critical thinking, and just has a really great storyline that kids love and can't wait to see the next part.
Yeah, and it's that student voice that you captured in that, and you use students to help design it, and that's very powerful.
Yeah.
And I think all of this speaks to the fact that no one entity can do this on its own. Yeah. And Ken, you mentioned that conveyor belt. You know, if you think about producing Panadol for headaches, right? You've got to have the chemists in the lab that are updating the research and finding the best formulation and the rapid acting. That's us at Matilda Centre. That's what we're doing in our collaborators at the other universities. And then, I was speaking to Lauren before about, look, we get excited about when a paper gets published in The Lancet. A lot of people don't. And look, we just have to deal with that. And so then along the conveyor belt, we've got a product that we think this is pretty good. We've tested it. We've gone through all the testing. It works. We've worked with young people. We've worked with teachers. It will fit within curriculum. It will fit within schools. Then it's got to go somewhere. How do we get it to go somewhere? And then along our conveyor belt, we hand over to OurFutures Institute, and that you've got the connection with schools and then the conversation with teachers. We don't have that expertise. And then having an ear on the ground, then that can feed back us to and go, well, the latest thing is illicit tobacco, or the latest thing is contamination with opioids in vapes. How do we then address that in our lab? It's a very cool lab, I have to say, and then feed that back through. So I think that's the really important part of this. So the uni can't do it alone, teachers can't do it alone, parents can't do it alone. You know, the physicians at the end line going, well, all I can do is treat what I'm seeing, but the impact beyond that, all the young people who are 5 now. How do we stop them getting there? And I think that's it's a collective effort. It takes a lot of collaboration, a lot of time, but this is where the value is, I think.
Can I just ask something on that, for particularly for you, Sophie and Emily? With trauma and injury in my role, we see a lot of drug, alcohol and vape associated, not associated, but patients who come in are young adults, severe injury. Their incidence of mental health disorder, vaping, drugs, other alcohol is overrepresented in that group, and the regional rural population is again overrepresented. And we put in a huge resource, with our medical services, and I work in that area and in trauma centres, and we were very upfront about huge investment at that time after the injury. And when I was reflecting on this research, I think this is bigger than just what has been done in vaping. I think this is actually going to affect risk-taking behaviour and potentially decrease the trauma burden, which is extremely expensive. And I'd ask you both to reflect on your personal experiences with that and with the research. Do you think this could go wider to that risk-taking behaviour and then getting in car accidents or falling off something?
Well, I think I think so, because with OurFutures, it's not just the vaping modules, but also the alcohol and cannabis modules, etc. The storylines really talk about looking after each other and what it looks like for kids for their friends, if they're under the influence, and what they can do to help them. I think that it's, yes, I think it's bigger than just the drug and alcohol side of it. I think it will actually, I know it does.
Yeah. And I think it's important to consider that any human behaviour doesn't occur in isolation.
Yeah.
And for adults, a good example is alcohol. You know, alcohol is very widely consumed. It's quite socially acceptable. It tastes nice. It's social, right? It's associated with significant injury and harm, particularly among young people. So if we can, so say, you know, you go drinking and then you choose to drive and then you have an accident, you hit a pedestrian, these are all traumatic injuries that relate ultimately back to the decision to drink and probably drink in a harmful way. If we take out that first step, or if we can get people to reduce the harms associated, so you have a drink and you walk home, all of those flow-on harms don't happen. So if we take vaping out of the equation, you don't vape, you're less likely to, where's Becky, smoke later on. You then take out all of that chronic health harms, which costs literally billions of dollars a year. You take that out. There's also a really close relationship between nicotine, smoking and mental health. But a bi-directional relationship, and we publish results from this from the OurFutures trial and the Health for Life trial with Katrina Champion. We're looking at, so young people who vape are twice as likely to say that they're depressed, and young people who are depressed are twice as likely to say that they've vaped. So there's this bi-directional relationship. So if you take one behaviour out, you're potentially preventing a whole host of other associated behaviours that go along with that. Drinking to cope is something that we cover at Matilda as well. They are all interrelated. So I think, yes, we do. If we start early and we talk about healthy behaviours and healthy coping, ultimately it's about how do you go through your teenage life and build resilience and don't, you know, fold to peer pressure, and identify and critically think about how you can be your best healthy self. Then the ultimate flow-on effect is everything else.
Absolutely.
Yeah, definitely.
The prevention education model, the ROI, you know, I'm so excited to see where we're at. Like when we've got these million students and the impact that we've had, what sort of model we can come back to the minister with to go, can you help support our other programs? I think we're close up the time. We've got 5 minutes. I'm going to take some questions. We've got one down the back.
Kids have moved from vaping to pouches. Can the methods from this program be applied to other substances as well?
Yeah, I might flick this to you, Emily.
Yeah, and I might flick to Lauren. The good thing about the program is that what we
Lauren, come on up.
just pass the buck. Did you want to talk about it, Lauren?
Go for it, Lauren.
So I think what's really important about this program is that it's teaching these skills and these coping mechanisms that aren't specific necessarily to that substance. You know, they're transferable. So in this original program, we do focus on vaping and tobacco, but these, as I said, we're teaching them these coping mechanisms that they can apply into other substances and other aspects of their life to help protect them and arm themselves with those skills. We do have another program in the works though that is focusing specifically on other nicotine product use like pouches. So yeah, we've got it all covered, don't worry.
Watch this space.
Which kind of speaks to the curriculum side of things, right? If you've got that flexibility for delivery and the design, you can start to do other programs. Any other questions?
Is there a relationship between this type of behaviour and gambling?
Yeah, good question. So the question's about risk-taking behaviour and gambling. I'm astonished what's going on with the stories we've heard with specifically young boys in year 10 and year 11 and year 12 on these gambling apps. It is unbelievable what's going on.
Yeah. And
but yeah,
it does. Absolutely. It all comes down to reward and that dopamine rush and that same thing. You know, people vape to get a hit. You gamble and you get a hit. You also get, you might, money alongside that. So when we talk about addiction and addictive behaviours, gambling is part of that. And a lot of these behaviours are interrelated, as I mentioned. So if we can try to address, the thing is not about taking away. With young people, it's always like, don't do that, you can't do this, don't have your phone, da 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 da. It's like, well, what can I do, miss? It's like, well, these are some healthy activities that divert away from those behaviours. So if we can intervene early, give the information about, and if it's not vaping, it might be gambling. You know, this is what's happening. There's an algorithm that's designed to trick your brain into getting this rush, and you're going back. That's addiction. That's the same thing as smoking. It's the same thing as MDMA. It's the same mechanism. But then go, well, what else can you do instead? Here are healthy coping mechanisms, and that's what we're trying to do as well. So it's not just the take away, but the give back instead, and the diverting behaviours. Yeah.
Maybe one more over here.
During the co-design process, do you consider the different ways kids learn?
Yeah, absolutely. You probably don't want to get up again, do you, Lauren?
Come on.
You can if you. The development process, what we do is we find the evidence and get the content, right? And then how that's delivered is ultimately a combination of the animators going, this is what looks cool, but then we take that back to the young kids and go, is this legible? Do you understand the terminology? What's really nice, which you wouldn't have seen in Lauren's slides, is that the characters are overdubbed with young people's voices as well. Yeah. So if you are not engaging with the visual, even though it's pretty appealing, you can listen to the storyline, you can close your eyes and just follow along. On the flip side, if the words are not your thing, you can listen along. So it's designed for, you can get the content through the auditory, but also through the written, and also there's tactile. If the teachers want to, they can print out the resources and have it tactile in front of you if a screen is not something that you want to encourage. So we have, obviously this is the first product that we've got that's out there, and there will need to be iterations, and we're working on iterations and updates and changes and accessibility. Translations are happening. I know Lyra Egan is doing some stuff in Colombia. So we get the base product and then add on from there, but it is designed to be accessible and to as many young kids. But there's also improvements that we can always be doing, and we need to engage with community to hear what that is, and engage with teachers and engage with parents and go, well, my kid couldn't do it because they can't use a device or they don't have one. So we've got to be constantly aware of that and not just go set and forget. We have to keep updating.
Can I just add to that though? I think it's happening in a classroom environment with a classroom teacher with that expertise in knowing their kids, knowing how they learn, how to adapt and adjust that lesson as well to be able to meet those needs. So I think it's that combination of the design, but also that professional judgment that teachers make in the moment about how they connect kids to the learning.
We're very close to time. I'm going to go to one of the board members. Joel, did you have your hand up before?
Is Year 7 the right age to teach young people about vaping prevention?
Yeah, I agree. It is a challenge for sure. I had a teacher say to me the other day, is the vaping module, can we do Year 10s? And I said, well, it's not really targeted at Year 10s because they've missed out, if you like. They're not too late, obviously, but yeah, they've missed out. I haven't seen or heard anything from primary schools about grade 5s, potentially grade 6s. Look, there may be pockets of grade 5s, but I don't think it's the norm. Maybe grade 6s, and I'll find out more this year because we've just, as part of our LDAT work with the Alcohol and Drug Foundation, just written a resource for parents around transitioning to high school. So I might find out some more then and perhaps have a chat to OurFutures about what I find out. Yeah.
Amazing. So look, we have to wrap up, I'm sorry. Let's thank the panel. Thank you all for coming. Great conversation. We do have a performance coming up. Just before we do, look, another shout out. There are so many amazing people here. We've got people from Queensland Principals Association. We've got local health districts executives. We've got senators and local council members. We've got MPs. We've had ministers. We've got leadership at the university and all around the community. And I think that ties into this being like it's all hands in. You know, we get on our Facebook page people commenting like, oh, you know, teachers shouldn't be, this is a parent's problem, and someone else replying, no, it's a teacher's problem, and all this kind of stuff. It's everyone's problem, right? So I think this is just recognised that this is a community issue, and as a community we can kind of, like we did with COVID, everyone works together, everyone kind of supports each other, and we can really make a difference.